Hello everyone, my name is Nadia Miknouzi and I'm sharing this video for compounding to get you ready for the MPJE Arizona State. If you are looking for the NAPLEX compounding, I do have a separate video for that. If you are getting ready to take the Arizona State MPJE, this presentation is designed for you with one goal in mind: to help you master compounding related questions and pass the Arizona MPJE with confidence. I've simplified all the key points, removed the fluff, and focused on what matters the most. That way we can get you close to the finish line. It's a very easy topics that can be in the back of your pockets. Roughly, I'll say 12 to 17 questions out of the 120 that you will have in your MPJE examination. USP 795. This is for non-sterile compounding. It applies to creams, ointments, capsules, suspensions. We need the master formulation record and the compounding record. The hygiene, it's very simple. Use of gloves and gown, hair cover if needed. Cleaning is typical. Daily before and after compounding of your compounding area, countertops, equipment, and all. And then monthly, which is walls, ceiling, and storage. However, what we will need to focus on is our beyond use dating. For non-aqueous formulation, 180 days, 6 months. Water containing oral suspensions per se must be refrigerated in its 14 days. Topical, 30 days, with one exception: in case of a use of a preservative, then it will be 35 days. I prepared a question for that. A pharmacist is preparing a compounded topical cream with an AW of 0.968 and a preservative. This is going to be my key point. What is the maximum beyond use date that can be assigned to this formulation? This is a typical NAPLEX-like question. It is topical compounded cream, non-sterile, water-containing. According to the USP 795, the beyond use date for it being a water-containing topical is 30 days. Or any intended durations mentioned in the problem, like therapy maximum date or whatever is shorter. In this case, the use of preservative does give us up to 35 days. I don't see the MPJE will be trying to trick you and put 30 days and 35 days. They might do like 14 days, 35 days, 45 days, and you will not see the 30 days and then you end up by picking 14. Or be confident. You see that preservative? It is containing water, 35 days. In this case, the water activity is above 0.6, 0.968 to be exact. I put a note in here. As far as if my water activity is less or equal to 0.6, that only reduces the microbial risk. It does not override or change the BUD for me. Another question. A pharmacy technician is labeling compounded ointment that contains white petroleum, titanium dioxide, lanolin. The combined formulation is for skin protection here, and the water activity is 0.43. The following are the individual expiration dates of these ingredients. So we have May, September, December of this year, and the problem is telling me if today's date is February 14, what is the most appropriate beyond use date to assign to this preparation? It is an ointment, non-aqueous, water activity is less than 0.6, low risk of microbial growth. That's how I see and what I read between the lines. Now, the USP 795 rule tells me that it should be 180 days, 6 months. When I look at the ingredients here, I do have an earliest expiration date of May 2025. Pay attention. That will be my expiration month because it's earlier. If I do the 6 months rule, I will fall on August 14. However, I have another component that's expiring sooner, May 2025. Now this might trick you. You will have May 1st, May 14, May 31st. Always pick the last day of the expiration month. Unless the pharmacy policy sets a different BUD expiration rule to the first day of the month, it is always the last day of the expiration month. So to answer this problem, my BUD is May 31, 2025. This gets us to USP 797, sterile compounding. We use it and apply it mostly for injections, ophthalmic, irrigation. This 2023 revision did change the categories to 1 and 2 on the BUD criteria. We'll get to it here in a moment. On the previous 795, the documentation required it's the master formulation record and the compounding record. However, for 797, there is 2 additional logs, environmental monitoring log and personal qualification logs. The hygiene, now we have shoe covers, hair and beard covers, face mask, sterile gloves, and a clean room gown. The categories, I put them into 2 separate slides. That way we can focus on each one separately. Category 1 will give you a shorter BUD, and it is controlled by the temperature. Room temperature, less than 12 hours. Refrigerated, up to 24 hours. One more time, beyond use date, 797 for sterile compounding. Category 1, prepared in segregated compounding area, controlled by storage temperature. Room temperature, 12 hours or less. Refrigerated, 24 hours or less. We do not do frozen. Category 2, it's not only controlled by temperature, but as well of the preparation conditions. Aseptic with sterile component and offers longer BUD and requires a full cleaning room with ISO 7 for the buffer area. Your anti room is 8 and your pack will have the 5 ISO. I put it in the order of the duration. If you're using one or more sterile component and aseptic processing, with no sterile testing, room temperature 1 day or less, refrigerated 4 days or less, and frozen 45 days or less. Now, if all my components are sterile, before we said one or more non-sterile in my component, but now if prepared aseptically using only sterile starting component, yet we don't have the sterility testing. Increases my room temperature BUD to 4 days or less, refrigerated 10 days or less, frozen stays the same 45 days. Next step up, if sterility testing is performed and passed, septic with sterile component, increases my BUD or room temperature to 30 days or less, refrigerated now is 45 days or less, and frozen extended to 60 days or less. If terminally sterilized with sterility testing passed, the word terminally will be your key in the question. Then room temperature is 45 days, refrigerated it's 60 days or less, and frozen now it's 90 days or less. Most areas you'll find category 2 is defined as room temperature 1 day to 45 days, for refrigerated 4 to 60 days, and frozen 45 to 90 days. That can be confusing sometimes. However, I gave you here the breakdown, the key points on the question, how many non-sterile components are in my formulation, are they in you or not at all, is the sterility testing applicable or not, is it terminally sterilized or not. The training and competence, we always do the initial training and then annually media fill test, gloved fingertips test, and then surface sampling. You might have an option that says initial but not annual media fill test, or the opposite, annual media test but no initial, or it might be a select all that apply. So make sure that you choose the one that does have both options, or if it's select all that apply, select initial and select annual media fill test. Cleaning requirement, daily the work surface and compounding area, the floors in the buffer and the ante room or area, as well as your pack. This is where it gets important. At the beginning of each shift, before each batch, every 30 minutes during use. Every 30 minutes during use. And of course, after spells and at the end of your compounding. Use only sterile lint-free wipes with sterile 70% isopropyl alcohol or EPA registered disinfectant. And of course, the sealing in the walls and the shelving storage must be monthly. Moving on to the USP 800. This is for our hazardous drug handling. It protects not only personnel and patients, but as well the environment from exposures of hazardous drug in healthcare setting. It's used basically for people that receives the drugs, that stores it, that compound it, dispense it, administer it, and as well it helps us know what's the safest way to dispose of these hazardous drugs, and they are listed in the NIOSH list. Now this list, it comes with categories: Group 1, Group 2, and Group 3. Group 1, anti-neoplastic drugs, I give you here an example like bleomycin, that's blenoxane. It's used for Hodgkin lymphoma, testicular cancer, and certain types of squamous cell carcinomas. So cancer drug, naturally it's a group 1. It does break the DNA strands, so it's up there on the hazardous level. Group 2, these are non-anti-neoplastic, non-anti-neoplastic hazardous drugs like hormonals, tacrolimus, Prograf, and they have even a topical brand for eczema and atopic dermatitis. I think it's Protopic, but beside the point here, it is very toxic, and therefore we must know exactly how to handle it and as well how to dispose of it. Then group 3, these are reproductive risk only. I've used here medroxyprogesterone. This one, Depo-Provera, it's a contraceptive and as well used for endometriosis. Very toxic. Isotretinoin, literally not only does have RIMS, but it have a very special RIMS called iPledge. It's a safety monitoring iPledge requirement. I know that they used to have a brand Accutane. It's discontinued in the US due to the very high cost. But they have a lot of brands out there and a lot of formulations. So all those containing products that contains isotretinoin on it must follow the iPledge requirement. It is teratogenic and category or group 3. The engineering controls that we use is the CPEC or CSEC. These have a control that helps us keep everything sterile, as well as there is a more advanced personal protective requirement for the individuals in the compounding area. I will mention them here, and I want to focus on a couple of things as I go through it. Chemotherapy gloves, powder free, worn in pairs, so double gloving. The only time that they use single gloving on hazardous drug is in the shipping area, where they just like receive and just store it. Everybody else must have double gloving. You change it every 30 minutes, or if damaged, of course, or there is a spill or so. Chemotherapy gown, long sleeved with closed cuffs, disposable, and you change it based on either the manufacturer instructions or every 2 to 3 hours. I remember when I took my exam, I had this 2 to 3 hours confuse me for some reason. After contamination, or 2 to 3 hours, or according to the manufacturer's instruction. Must have eyes and face protection. For respiratory protection, N95 or PA/PR if needed. Going next to look at few terms and definitions. You must already know this, but it is important for your examination as well. The activation, we're neutralizing the hazardous drug. The contamination, we're removing the residue. Cleaning, we're removing everything organic, inorganic materials. Disinfection, we use the EPA registered disinfectant for our sterile area. Receiving and storage. Unpacking, must be in a neutral, negative pressure area, not in the sterile compounding area. Hazardous drug must be stored separately in a negative pressure room. You can always go back to this video. Everything that I have in bold, it's important. No storage on floors, no positive pressure storage. Your personal training must be done, of course, before handling hazardous drug, and it's repeated yearly. Competence must be documented, as well as medical surveillance, is recommended, and as well, all hazardous drugs must be labeled. They often have hazardous drug, handled with care, so that's a must. And you'll see that as well on section when you're studying for your labeling. Question. A pharmacy technician is compounding an intravenous dose of ceftriaxone for hospitalized patient. The preparation involved reconstituting a 1 gram vial of ceftriaxone with sterile water for injection, followed by dilution with 100 ml of 0.9% sodium chloride in an IV bag. The compounding is performed in certified ISO 5 laminar airflow hood located within an ISO 7 buffer room and an ISO 8 ante room. The technician follows a master formulation record and uses aseptic techniques. No sterile testing will be performed. Based on the USP 797, what is the appropriate risk category for these compounded sterile preparation? Let's break it down. I see it's an IV. I know it's a sterile formulation. Prepared within ISO 7 buffer room. Perfect. Check. It is using an ISO 5 laminar airflow workbench. Perfect. It is located in a classified clean room with an ISO 7 and an ISO 8 ante room. Great. It is compounded aseptically, using only sterile ingredients. Check. No sterility testing performed. Okay, that's fine. Now, if we look at all of these factors, when I see the question, I highlight the things that are significant for me. Therefore, this places it on category 2. If for any reason it would have said this was done with sterility testing, on a moment here we'll go through the outsourcing facilities, which is the 503B. They do get extended storage, and this will category into category 3 for them. But for the purpose of our examination, we did that check ISO 8, ISO 5, ISO 7, aseptic techniques, category 2. This is our areas and the required ISO. I'm sure you know this already. Otherwise, it's there for you. Next here, a question to test our knowledge. A pharmacy intern is preparing an IV admixture by reconstituting a 1 gram vial of ceftazidime with 10 ml of sterile water for injection, then transferring it to an IV bag containing 0.9% sodium. To maintain sterile conditions, the compounding must be performed within a primary engineering control that provides which of the following features? Select all that apply. A. Positive air pressure. B. ISO class 5. C. Unidirectional airflow. D. Negative air pressure. E. Use of Class 1 biological safety cabinet. F. Use of ambient room air with HEPA filter only. Let's tackle this one by one. Positive air pressure. For non-hazardous sterile compounding, the PEC is placed in a positive pressure ISO 7 buffer room, like the laminar airflow or the CAI. This helps keep the contaminant out. Check. I like that answer. ISO class 5 air quality. At least ISO 5 air quality is needed, must meet the ISO class 5 standards. So I will keep that too. I like that answer. Unidirectional airflow, laminar flow ensures the air moves in one direction to sweep away particles and maintain clean conditions. So yes, definitely. D. Negative air pressure. This is used in hazardous drug preparation. Now, when I look at my medication here, ceftazidime, it is a non-hazardous sterile compound, so I am not going to worry about the answer. I don't like it. E. Class 1 BSC, it does not meet my ISO 5 requirement. And F. Ambient room air, it fails the ISO 5 air cleanliness standards. Therefore, my last pick is A, B, and C. Very well. This should be an easy question. Just always break it down to what type of compounds you're dealing with. Are they hazardous? Are they not? Because that will make answering faster and a way easier. I put this in here because although it looks like it's a second nature for us pharmacists, it could be confusing in the order it's done. So just go ahead and read through it, put the scenario in your head over and over, and it will help you not confuse the ordering of the hand and the Garbin sequence, the hand hygiene and the Garbin sequence. We have another concept for the USP 797, which we have two phases. The first one is for 7 days. It's done on 20 Celsius to 25 Celsius at room temperature. And then the next 7 days, we incubate it in warmer condition, usually 30 to 35 Celsius. And both these phases must show no turbidity, which this will indicate for us no microbial growth. Now, you might get a question, how long must the sample remain free from turbidity to pass the media fill test? Your answer should be 14 days. Unless they specify a room temperature or in the incubator, it is asking the total incubation duration, 14 days. Easy question, easy point. We have as well here another concept. It's the AOR. So according to the USP 800, they do have an assessment of risk that's permitted only for specific dosage forms of the anti-neoplastic hazardous drugs that you'll find listed on table 1 in the NIOSH list. The AOR may be applied only when the drug is in its final intact dosage form. That's it. From that form to the patient. It does not require any further manipulation. No compounding, no crushing, no mixing. And I give an example here to where it's appropriate. Example of activities where an AOR may be appropriate includes counting or repackaging, intact tablets or capsules, highlight the word intact of certain anti-neoplastic agents. The drug must remain whole and unaltered. You cannot cut it half, you cannot crush it. And classifies by source such as MSHI, NTP, or the IARC, Group 1 or 2A. Example, let's look at tamoxifen tablets that is packaged into a unit dose blister packs. Is this eligible for an assessment of risk? Answer is yes, because it's repackaged into unit dose blister pack. Does not require any further manipulation. You don't need to crush it further or split it, or no compounding involved, no activities to determine that it's not qualified for the AOR USP 800. Again, there is a list of the NIOSH that you can look at and try to memorize these names, familiarize yourself with them, brands as well as generic, because you never know what name they will throw at you. This is just a table to give you when the AOR statute is allowed and where it's not, and you see right on the first option, repackaging tablets and capsules, the description according to the MSHI and the NTP, it's intact, solid dosage form unit, packaging. Another alternative one that doesn't, it says here, splitting or crushing tablet, alter the dosage form, create dust. Very well. I put a list here. The ones I highlighted in red, those are my cancer drugs. And then the most that you've probably that you'll encounter in questions um, for the purpose of the MPJE, all states. I put both the drug name, generic and brand, cyclophosphamide, cytoxane, methotrexate, Trexel, doxorubicin, cisplatin, etoposide. It is convenient sometimes for you to face a brand in a question that probably it's well known to the question writer based on their like situations that he encountered or expertise, but it might not be common to you because let's say you did your rotations in different focused pharmacy or clinical subjects. Your opportunity to cross-reference with all the drugs is while you're preparing for your NAPLEX and MPJE. So the more you practice, the more you become more familiar with some brand names that you never encountered in your pharmacy school life. USP 800. Let's look at this question here. The USP 800 and USP 795 and USP 797 might cross paths to where you can find a non-sterile that's hazardous and you can find this drug that's sterile and hazardous. When we look at this question here, I used colchicine, and the question asks which United States pharmacopoeia standards is best consulted to determine the personal protective equipment requirement while compounding an oral suspension liquid of colchicine. That's Colchris. It's used for gout, used for FMF, It is hazardous drug, definitely by the NIOSH list. When I look at this first, I see that USP 795 can be consulted on this for the preparation standards. This is not a sterile compounding. However, I'm not going to use that beyond use dates because they're asking me about the PPE, personal protective equipment, right? Protective, if I use the 795, it's the simplest of them all, just gloves and gown. But this is a hazardous drug, so I need to use the USP 800. If it's select all that apply, easy pick. USP 795, USP 800. If it is asking me for a PPE, the personal protective equipment or gear, now I need to see which one is more important, and it is a hazardous drug, including the personal protective equipment. Should be an easy pick for you. But do not rush into answering the question. Break it down, and you have like an average a minute and 20 seconds per question. So trust me, it takes like 10 to 15 seconds to read the problem. It's not like NAPLEX where the question is super long. MPJE, it's very straightforward, and you should put your priorities online, and I'm sure you will pick the right answer. The FDA and State Board of Pharmacy, very, very strict. They scrutinize the compounded topical pain creams, especially those that are made with high risk or bulk ingredients. I gave here an example like ketamine, baclofen, and gabapentin. In fact, they have expressed concerns about compounded pain creams with high concentrations of this active pharmaceutical ingredients, like citing risks such as toxicity, absorption, and especially with all the components out there, they don't have proofs of efficacy at higher doses. Yet, due to a lot of complaints and um, uh, medical error reports, there is a higher ADRs and adverse effect. So many states or many boards here follow the guidelines that's influenced by the FDA, memoranda, or clinical evidence, which often restrict ketamine concentration to 10 to 20%, gabapentin to 10% or less, baclofen. Baclofen, it's the most used if you see even over-the-counter products and all, to 2 to 4%. Concentration higher than these are generally considered unsafe or not supported by available evidence. We just said that, and especially for transdermal absorption. What I tried here is that put the most generic brands and the compounding range. If you look at it here, you'll see lidocaine 1 to 10%, Elavil, amitriptyline 2 to 10%. I'll give you an example of a question here. Let's say we are making a fibromyalgia or CRPS or a topical neuropathic pain cream. So we send it to the compounding pharmacy and we ask them for 14% of ketamine, 10% of gabapentin, and 2% of baclofen. True or false? This is a safe compound. True. Yes, 16, it's more than the preferred 5 to 10%. Mostly you'll find 15%. That's why I highlighted it in red. These people are using 16%, but technically as far as it's less than 20%, it's a go. Gabapentin, I don't remember what I said, but I'm sure that I picked a number below 10. And baclofen, I don't remember, I think I said 2, but I made sure that it was less than 4%. So yes, true. Another question, true or false? We're making a cream for neuropathic pain using 10% of cyclobenzaprine, 10% of ketamine, and 15% of lidocaine. Is this a safe compound? False, because I passed the requirement for the 10% using one of the ingredients at 15%, which is not a safe compounding range. I think you have an idea about the type of questions you'll be asked on these. Current good manufacturing practices. They are FDA enforced. There are quality standards to ensure the safety and purity and consistency as well of these drugs or the drug products. There are entities that must follow them and there are entities that doesn't follow them. I put them here simple for you. It could be select all that apply. It could be a straightforward question. You must know the entities that must follow CGMP are drug manufacturers, 503B outsourcing facilities, API manufacturers, and contract manufacturers. Entities that does not follow CGMP, 503A compounding pharmacies, retail and hospital pharmacies. Now, compounding facilities or pharmacies, when you see the 503A, these are more of small compounding pharmacies or facilities that does compound specific medication for specific patients. While the 503B as in boy, they manufacture and compound bulk compounding formulations without specific prescription for a specific patient. I remembered it with B for bulk, so you never twist these two. In fact, I put here the key differences for you. That way you can differentiate between 503A, which is more like your compounding pharmacy or specialty pharmacies that are more traditional, and then the 503B, which we refer to as outsourcing facilities because they deal with bulk. Safety Data Sheet, SDS, formerly known MSDS. The funny thing about this, I had 2 questions on this when I took the Arizona State MPJE. It surprised me because I definitely knew what it looked like. I'm sure I read it more than once in different drugs. I just did not expect it, so it caught me by a surprise. However, it is required by OSHA, so OSHA. It is under the hazard communication standards, and it provides detailed informations on the hazardous like drugs and handling them, storing them, emergency response related to the hazardous chemicals involved in, and include as well hazardous drugs. Like I don't remember which drug I had. Just going to pick here Valglas Valganciclovir. This one yeah, this one it's I forgot the brand name, but it is a teratogenic, carcinogenic drug. It's used for CMV. It's an antiviral, and I don't remember what the question was, but I remember the knowledge it was needed from me. I highlighted the 2, 3, 4, 6, and 8 because it could be select all that apply. What does safety data sheet inform you of or include? Is it A, hazardous identification? Is it B, chemical identities and concentration? Is it C, BUD of these drugs? Is it D, safety disposal practices? And you select the ones that are included in the safety data sheet, which all of the ones I mentioned except the BUD. Or it could be which of these answers below does the safety data sheet um, or requires the safety data sheet. And you'll have like OSHA, you'll have uh, HIPAA, you have, and you select the right answer. So it is required by OSHA and it works under the HCS, which is the Hazard Communication Standards. 1 to 2 points that I faced personally. I don't remember the exact question. It wasn't my strongest suit at the time I took the exam. I knew what it was. I've read it a few times. In fact, I worked during my rotations on different rotations. They inquired me working with hazardous drugs. So I've read few of them. I just did not expect to see it in an MPJE examination. The EPA RCRA regulations. They categorize hazardous waste and generators based on the quantity of hazardous waste they produce each month, like warfarin, nicotine, epinephrine. They have two different categories: very small quantity generators or large quantity generators. The question on this in NAPLEX will be like, which one defines this manufacturer that does have a waste of 1,100 kilogram per month? Or what is the accumulation duration of hazardous drug permitted, which it's 90 days. So let's go over it here very quick. Very small quantity formally is like for facilities that are generating no more than 100 kilogram, that's 220 pounds of hazardous waste, or 1 kilogram of acutely hazardous waste per month. They're both per month. The difference is it acutely hazardous waste? Because if you just remember 100 kilogram for small and 1,000 kilogram for large, and then they put 2 kilogram of acutely hazardous, and you're like 2 kilo is the less than 100. No, keep in mind, acutely makes a huge difference from 100 to 1 kilo maximum. Now, if it's given me in the problem 2 kilograms of acutely hazardous, automatically it is a large quantity generator. Very easy, straightforward concepts, but during the exam, you have exam stress, you have fast-paced answering requirement. You see one, you see two, you know that it's less than 100, you answer too fast and you cannot go back. So please read the question, break it down. 100 kilograms of hazardous waste or one acutely hazardous waste per month or less, it is a small quantity generator. If it's more than that, automatically it's a large quantity generator. Don't miss those easy questions. This is just a table just to show you each organization and what's their role. Like OSHA, we just said, enforces general work, place safety laws. They inquire the safety sheet. You have there the JAPHA, which is a journal that publishes research, but it does not um, produce any guidelines. You have the NIOSH that does give us the list of hazardous drugs. I will definitely invite you to look at the lists and the table, all the 1, 2, and 3 categories, and familiarize yourself with them. Everything that I've shared with you, it's according to the Arizona State Board of Pharmacy, following the compounding regulations, the USP 795, 797, and 800 standards. I did not include any details or informations except I've shared with you my experience as far as how I do tackle these questions and how I answer them. If you have any questions, if you like this, if you dislike it, please feel free to leave me a comment. If you have any questions that are meaningful to you and you need to know more about it, or you just would like, to ask a question, this video I focused more on answering compounding MPJE for the state of Arizona. I want you to get these questions. I've done other videos as well to tackle different subjects on the Arizona MPJE as well as the NAPLEX examinations. Please look at those. I hope this helps you. Again, my name is Nadia Miknouzi. I wish you the best, and you've prepared for this. You are still obviously watching this video. Now go show them what you're capable of. Stay focused, stay driven. You know this. You just need to learn how to read the question and what they're looking for. Read the key words on each question that might change the answer. Like earlier when we talked about the hazardous waste and how many kilograms, is it acutely hazardous or is just a hazardous drug? The BUD, is it room temperature? Is it frozen? Is it category 1 or 2? Now, if it's 30 days for, let's say, not using the preservative, now we have preservative, is it 35 days? So those small things makes a huge difference on you selecting the right answer. And please let me know if these helps you once you take your MPJE Arizona. Please share it in the comment, that way other students like yourself, when they are approaching this video to help them, they can see your feedback, and it is welcome either way. I just want you to please share with everyone in the comment instead of a private message, that way other people will as well read it and maybe it'll be meaningful to them. Thank you again, good luck, and I'll see you in another video.